Hello friends, I am presenting a case of redo myomectomy. A 37-year-old nulliparous woman had a history of myomectomy done 10 years back. Now she has multiple fibroids and wants to undergo IVF, and her consultant advised myomectomy before going for IVF ET. We started her with a hysteroscopy. There were few adhesions in the fundus of the uterus. We can see, barely we can visualize the right tubal ostia. It is appearing like a two separate cavity. It simulates a partial septum. It could be because of the previous surgery which was released with the cold scissors and to make the endometrial cavity as near normal as possible. Few snips near the fundus of the uterus were sufficient to make it a normal, and in a panoramic view we can see both the tubal ostia which may be helpful in improving the IVF ET results. So that's the right tubal ostia which can be seen now, as it was obscured in the beginning of the surgery. So this is a view of laparoscopy where fallopian tube is seen normally. Few adhesions are present. Right tubal femoral end, which is also seen normal. There are few adhesions on the fundus of the uterus. We can see multiple fibroids are present both anteriorly and posteriorly. The idea of presenting this case is mainly to understand that previous myomectomy would have produced significant adhesions if proper hemostasis is not maintained and approximation of the incised ends were not there. So as routinely, we started a surgery with the vasopressin injection into the uterine cavity in 10% dilution. Few sigmoid colon adhesions which may be normally seen are released to get a proper access so that sigmoid colon can be moved away from our surgical area. Now we have started the surgery with the myomectomy, taking incision, vertical incision, and the as lowest fibroid as possible. Hormone scalpel was useful in making an incision with a less smoke, with a good visibility. As there are multiple fibroids, we try to take out as many fibroids as possible in a single incision, and the anterior fibroids were taken with a separate incision. There was a worry because of the previous myomectomy. There could have been significant adhesions, but to our surprise, it was clean. Her previous myomectomy was done in our hospital only. and we had used interseed to cover the incision. And to our surprise, there were not much of adhesions which were present of intestine or the omentum or the uterus. So once we are taking incision, myoma screw is used to manipulate the fibroid, and harmonic scalpel is used to separate the myocytes, myometrium from the fibroma, so that we can have a clean and shiny myoma coming out. So even though fibroid is coming easily outside, but it should not be peeled off in a quick way to prevent bleeding. It should be easily dissected out of its bed, and all the myometrial fibers that are adhered to the myoma are dissected out, and then enucleation of the fibroid is done. So we can see few more fibroids can be released through a single vertical incision. So vertical incision was preferred over the transverse incision, as the fibroids were seen more accessible through the vertical incision. If it is single large fibroid, we would have gone with a transverse incision. So whichever is ergonomically feasible, and preventing the lateral extension of the incision out of the uterus, which will have a increased chances of extending our incision into the uterine vessels, can be prevented. In either way, the dissection should be meticulous, slow, and under vision, where harmonic scalpel will have a major advantage in this. It can be very well done with a cold scissors or even with the unipolar, but their energy use will be more. There will be lateral spread, and there will be more amount of scarring of the tissue. This is one more fibroid has been released through the similar incision. So in one vertical incision, we could remove nearly 4 myoma of 3 into 2 centimeter and 2 into 2 centimeter, and one more 2 into 2 centimeter. So as we remove the more and more number of myoma, the shape of the uterus becomes near normal, which may improve the chances of fertility. As the multiple fibroids in the uterus will have a effect over the vascularity of the uterus, barbed suture is used to approximate the sutured incisor ends, and it is giving a uniform tension, and it is easy to manipulate the sutures even in a difficult access area like this, where vertical incision down in the uterus near the isthmus is more technically difficult. So in such a situation also, barbed sutures becomes very easy to handle. And it maintains a good hemostasis at the end of the surgery. While taking bite through the lateral ends, care should be taken that the needle does not go out of the uterus, where there may be inadvertently injury to the vessels in the broad ligament. So with this we come almost near to the end of this suturing of this incision. Which gives a normal shape to the uterus and uniform hemostasis is achieved. Similarly, anterior fibroids were also removed. And hemostasis is achieved. We can see there is a vascularity of the uterus, which is now turning into pink in color, and there is no oozing of blood through the incision, which once again confirms that there is a good hemostasis. To prevent adhesions, we routinely use oxidized cellulose, that is interseed, to cover the inside side. Thanks for watching this video.